All right. Well, hello everyone. Good morning. Yatea Bene. Um, it is now 10:02, so we're just going to give people about another minute or two to start trickling in. But thank you so much for joining us today for our featured presentation with Dr. Jennifer Erdrich. All right, gonna give people just a few more minutes. We will start promptly at 10:05, so less than 2 minutes now. But thank you again to those who have joined us. All right, the time is now 10:05, and again, we will just be giving folks a little bit more time to join us, but as they're starting to trickle in, I do want to say hello and yate. Thank you all for joining us for our featured webinar presentation as part of the Center for Native American Cancer Health Equity quarterly webinar series. It is fairly new. We just started it this year, so we are so happy to have you all here. Um, to start, since I will be your moderator today, I do want to do just a quick introduction. My name is Jennifer Hudson, and within C-NACHE, I am the Senior Community Program Coordinator, and I am also a citizen of the Navajo Nation. So just to establish some kinship relations to any Diné relatives I have in the room, I am of the Mountain Cove clan, born for the Blackstreet Wooded people. My maternal grandfathers are of the Cowering House clan, and my paternal grandfathers of the Water's Edge clan. And I am also assisted today with my colleague, Carmen Lita Chief. So Carmen, I will turn it over to you just to provide your introduction.
Thank you so much, Jennifer. Hi, everyone. My name is Carmen Lita Chief. I work alongside Jennifer as a senior research coordinator with the Center for Native American Cancer Health Equity. I will be helping with the chat messages this afternoon. We're all happy to have you here this morning, and that is who I am. Thank you.
Great. Thank you so much, Carmen Lita. So the focus of today's webinar presentation, if you saw all of our flyers and promotions, and as you can see on the slide here, will be focused on enhancing multidisciplinary cancer care for tribal communities from a surgeon's approach with Dr. Jennifer Erdrich. We will allow some time for her to more fully introduce herself when she begins her presentation. But as for now, she is a surgical oncologist and assistant professor at the University of Arizona. And we are so delighted to have her join us, and for myself to have another Jennifer in the room. So glad to have you here, Dr. Erdrich. And as just a general courtesy to our audience and an FYI to you all, this event will be recorded, and the recording will be available on the C-NACHE website. And I also do want to acknowledge that this webinar is funded by the American Cancer Society. And I'll get into a little bit more on that later, but I'll go ahead and move on to our next slide here. This is our setting our intention slide, and if you've joined our previous webinars before, you will remember that this slide has been up to set our intentions for today, and really just acknowledge the understanding that many Native American and Indigenous communities find the topic of cancer somewhat prohibitive or taboo. So we do want to acknowledge that within the space we have today, and acknowledge the different communities we have in the room. And really just our intention with the webinar series is to approach these topics with the utmost respect and care. And that means taking into consideration the spirituality that we know is integral to many Native American health models. So for this reason, we do want to allow about 45 seconds for yourself to kind of set your intentions, communicate that in your own cultural ways and your own practices. And this could just be for communicating what you want to get out of today's webinar, or even seeking some type of protection, whatever would be most comfortable to you all. And yeah, really just put those good thoughts out there. So I will set a timer just for about 45 seconds or so. So if we could all just take the time to communicate those intentions, and then we'll go ahead and get started with the rest of our webinar. But I will leave that time for now. So please do that as is comfortable for you. Okay. That was about 45 seconds. And I do want to thank you all just for your engagement in the practice of the intentionality. It is something that we do want to continue with this webinar series, again, just due to the topics at hand. And as we move forward, we also just want to recognize the importance of land and connection for Native American health. So I'll go ahead and move on to the next slide here. But what you'll see here on the slide is if you're here at NAU or on the Flagstaff campus, you'll recognize the Native American Cultural Center there, and in the back, the rest of the campus, but also a mountain that is sacred to 13 tribes in the region, and is known by its colonial name as San Francisco Peaks. But the mountain, as I said, is held sacred by 13 Native nations in the region. And so at this time, I do just want to provide the university land acknowledgement. Northern Arizona sits at the base of the San Francisco Peaks on homeland sacred to Native Americans throughout the region, and we honor their past, present, and future generations who have lived here for millennia and will forever call this place home. All right. And so with that acknowledgement, I'll go ahead and move us on. into just a little bit more background about C-NACHE and who we are. Um, just a quick primer on that. You can see that we are fairly new. We were established in December of 2022. And as I mentioned before, we do receive grant funding from the American Cancer Society that was awarded to Northern Arizona University. And a big goal of our center here is to reduce the unequal burden of cancer and advance cancer health equity for Native Americans with these 3 bullets here. We do have a focus on cancer screening rates, access to cancer care services, and exposure to cancer-causing environmental contaminants in Native American communities. So that's a little bit about us and kind of who we are at C-NACHE. And then I'll go ahead and move us into this slide here, which is about our webinar series. If you're familiar with C-NACHE, you may know that we have a lot of different activities going on, but one of our newest ones is this quarterly webinar series. We had our first one back in March, a second one in June, and now we're having this one in September. So we do have one more for this year, but we're really excited with what we've been able to share so far, what audiences we've been able to reach. But really if you've seen the promotions and the flyers going around, you'll know that this series is really committed to spotlighting the different types and aspects of cancer research occurring throughout Turtle Island, especially with a focus on the Four Corners region. And all of that to understand how they impact and the prevalence of cancer within Native American communities. You'll also see that a big audience that we're intended to reach is the Native American college and university students. So we are striving to demonstrate that there are diverse fields of knowledge that can contribute to cancer research, from the social and behavioral sciences to biological sciences and beyond. I think when we first think of cancer research, the first thing that we think is lab science or bench science with beakers and goggles, all of that. But what we do want to showcase through this series is that cancer research is multidisciplinary, and there are many ways you can contribute to advancing cancer health equity. And that's just another way we want to educate the next multidisciplinary generation of cancer researchers and advocates within Native American communities. So shout out to any students that are joining us today. We're looking forward to all that you'll learn from Dr. Erdrich and her presentation. So with that said, we'll go ahead and move into this next one. I believe right here, Dr. Erdrich, I will gladly hand it over to you, our featured speaker, and we'll allow her to introduce herself at that time, and then we'll go ahead and get started into her presentation. But again, thank you all again for being here so much, and for Dr. Erdrich for sharing her knowledge and wisdoms with that. Dr. Erdrich, I will transition over to you now.
Well, thank you very much. Can you see my slides?
Yes.
Okay. All right. Well, thank you all for allowing me to have this opportunity to speak to you today. I'm really excited about what C-NACHE is doing, so it's an honor to be here. My talk is entitled Enhancing Multidisciplinary Cancer Care for Tribal Communities, a Surgeon's Approach. As an overview, we'll cover some background, talk about my practice and research, my journey into academics, and then closing remarks before the Q&A. So I'm a surgical oncologist, as you heard. What that means is that I did general surgery residency, and that was followed then by surgical oncology fellowship. I'm board certified in both general surgery and surgical oncology. I practice at the University of Arizona. You could say the University of Arizona Cancer Center. You could say Banner. There are actually a lot of identifiers just with the one position. At this point, I'm really focused on operating on breast cancer, melanoma, and sarcoma. I do Native American cancer research. And then we're all centered in families of varying kinds. So I am a wife to a wonderful husband and mother of 2 lovely daughters. I am Turtle Mountain Ojibwe on my father's side. This is a picture of my great-grandfather. He was tribal chairman, and he was really well known for his powwow dancing. And that's me in my jingle dress. I can't say the same, that I'm known for my dancing, but I get out there and do it. I think that it's helpful to kind of see the area that we come from when we're sharing our background. So the picture at the top gives you a sense of what Turtle Mountain looks like. It's located in Belcourt, North Dakota. So really tall grasses, big open skies. That's what it looks like in, summer. A lot of the year it's drenched in white snow. North Dakota is a rectangular shape, despite how Zoom stylized it into this circle. But you can see that it's really close to the Canadian border, just 10 miles away. And then in the center, that's kind of a fuzzy picture of some of our beadwork. We're really known for our floral patterns. And then we're Northern Plains culture, which means we're powwow culture. I did not grow up at Turtle Mountain. I grew up in San Diego, California. That's where I was born and raised. Both my parents are from North Dakota, and that means all of my extended relatives are in the Dakotas and the Minnesota area. So we spent a lot of time going back and forth. I think of it as I had the best of both worlds. So during the school year, I was in some really rigorous schools from an early age. Even in high school, I was in an all-girls college preparatory high school. And then I got to spend summers in North Dakota and learn from all my relatives, learn our traditions. And it was just really wonderful. In terms of my research, this is always kind of tough. Well, what do you talk about? So I guess I should talk about, well, what am I working on right now? So you can't cover it all. So I'm going to kind of go over what's kind of fixating my attention nowadays. So what I'm really interested in is the obesity, inflammation, cancer link. And I think that metabolism is at the center of discussions around cardiovascular disease, obviously obesity, diabetes, aging, even our cognitive function. But what hasn't always been as apparent is this piece about cancer and how that fits in. And I'm particularly interested in the inflammatory pathway toward cancer. So we know that inflammation can lead to tumorigenesis. And then I think what's less commonly understood is that obesity is a pro-inflammatory condition. So obesity raises inflammatory levels, and when that is chronically active, it can be a pathway toward cancer. And maybe that's better understood here in this picture. So on the left screen, you can see that represents acute inflammation. On the right screen, chronic inflammation. And when our inflammatory system is working as it should and just turns on for a short burst, it's actually anti-tumor. So the schematic is showing that tumors are actually dying as a result of acute inflammation. But we're in a day and age with a lot of chronic stressors, a lot of environmental exposures that are turning our inflammation on chronically. And so then we have constitutively active molecules that are actually promoting tumor growth. And so that's the area that has captured my attention. So that's kind of part one of the science. Part two is that I'm interested in promoting prehab. So historically, my field has done an operation and then expected patients to deal with the aftermath in the postoperative setting. So it's all about rehabilitation. But in the last, I would say about 10 years or so, there's been a lot of movement in prehab. And the idea is that why don't we optimize our patients before we operate on them? And I kind of think of it like sports is the way I'll explain it to patients sometimes. We have athletes who have a game day. They, of course, are going to practice before that game day. So why do we expect that we bring our patients to the operating room for their operation, which is like a game day? It's a very demanding stress on their bodies, The general anesthesia changes their physiology, and we're expecting to handle that game day without having done any prep. So we're in an era where we're starting to really think about optimizing patients before their surgery, and we call that prehab. So that's part 2 of the science. And what I've been doing the last several years, and NACP, which I know many are familiar with, has been very instrumental in helping me to pursue this, is I'm putting together the science of inflammation, obesity, and cancer with prehab to create a prehab that reduces inflammation and improves cancer outcomes. And I'm doing this in partnership with the San Carlos Apache. So we have an anti-inflammatory prehab. The components of this prehab were based off of published programs. So we're starting off with something that exists. It's out there. It's just never been offered to an American Indian audience. And so we have a foundation to build off of, but then the opportunity to tailor it and make it culturally relevant and community specific. So we've done this with the input of the tribal health facility, and then tribal members who are cancer survivors that I interviewed. And the schematic is showing the components that go into this prehab. So we're doing nutrition counseling, 30 minutes of daily walking. Twice a week, there will be 60-minute resistance training sessions, and those are at the fitness center that's at the tribal health facility and run by fitness instructors there. So it's Apache people training Apache people. There's transportation assistance for those who need it. Education and encouragement is a big part of it. And then the anti-inflammatory foods that I'm having them eat, it's walnuts. So 2 ounces of walnuts daily, because they're anti-inflammatory powerhouses. And I had provided a list of different food items, and that was the one that seemed the most palatable to people. We've gone through a comprehensive IRB approval. So it's been through 6 IRBs. It's taken a really long time, but that's important. And then this will be the first prehab for American Indian cancer patients, and we're really close to actually enrolling patients. So I think in the next couple of months, we'll be able to do it. And what we're trying to find out is if this is going to show that we change the biology of the tumor. So can we actually change the biology of a tumor by doing these things? And to drill down on that a little more specifically. So in the center, you have the prehab, and it's for 3 weeks. So this isn't long. It's not meant to prolong surgery or put any treatment off. What my experience is that patients, it's generally at least a 3-week turnaround from the time they're diagnosed to getting them in the OR. So we're not going to prolong anything. They're going to do this prehab for 3 weeks. We'll measure inflammation in blood and in the tumor tissue itself, pre and post intervention. So we're going to be measuring the inflammatory markers from the diagnostic biopsy and then from the surgical specimen itself. We don't have to have the patient do any extra procedures. This is all just something that's done as part of their clinical care. And then what remains and is, otherwise not going to be used, we can measure inflammation in it. So in terms of the bottom portion, we've completed the adaptation, and that has been probably the longest part. But I think of it as kind of like the operations that I do. A lot of times there's more that goes into the setup and the positioning, making sure you have all your instruments, all your equipment, that the patient's properly cushioned and secured, and then we operate. So anything that, if you want it to go smoothly, go well, it has a lot of setup. So that's what we've been doing for years. And now it's an exciting time because we're about to pilot it and enroll patients, and then we're going to be measuring the biomarkers to see if we changed inflammation. And that's working as a proxy of, did we change the actual tumor microenvironment? So what makes prehab a good fit? I think it's kind of a shame that this hasn't been done for Native American populations before, because it's actually really intuitive and something that our ancestors did. This is the way they lived. They ate well. They had a lot of physical activity just built into their lives. So they were living anti-cancer lifestyles before it ever got such a label. So I think prehab really is a good fit for Indigenous populations. It builds on the theme of food as medicine, And I think that also contributes to the wider national conversations or international conversations about food sovereignty. We're using physical activity for resilience. It's not about weight loss. I don't want my patients to lose weight before the operation. This is about getting stronger. And then it's a lifestyle intervention rather than a drug treatment. So we're not just, throwing another drug at something. We're actually trying to use what we can within our capability to make an impact on the tumor. It's a holistic approach, so we're not doing just diet or just physical activity. We're doing both of those and more. Other prehabs will, of course, focus on substance cessation, and that's part of ours as well. We welcome traditional healers in it. So we're trying to use, a broader sense of approach to healthy behaviors. I think that it also has the ability to empower the individual and the community. So one thing I see with patients when they're on their cancer journey is that there's a lot of a sense of helplessness or isolation, and this feeling that people don't have any control, like everything is happening at them. And this is something that is totally within the power of the patient to do. They get to walk and they get to do it when they choose and how they choose. And it gives them some sense that they are contributing, that they have an ability to control their therapy. There's an emphasis on balance, and I think balance makes a lot of sense for a lot of different principles that we all have from whatever background we're coming from. And like I said, our ancestors did these practices. Switching gears a little bit and kind of getting to what the title was about, I think a lot about what models of care can improve clinical delivery. And I think there are kind of 4 different conceptualizations. There's business as usual, which is the idea that we have the major tertiary center and we just expect everyone to come to us. And that's how it often is done. And for people who are living on the reservation, that entails a lot of many challenges that aren't faced if you're immediately living in the vicinity of that tertiary center. So long distances. There's another model, which is phone a friend. And by that, I mean, I have friends who are working for different tribal health facilities, IHS facilities, and they might call me and say, this patient of mine got diagnosed with cancer. Can you help? And I can, and I like it in the sense that it's very personalized. It's a way to get someone really individualized and faster attention. But it's not scalable. You can't rely on that to actually address the needs of all of our cancer patients from our tribal communities. So then I thought about it, and this concept is second Earth, is what I call it. So I think of our cancer center as like a planet, and it has so many people coming to it with so many different skills they're bringing, tons of resources. And I have pondered, well, if we were to create a cancer center at a tribal facility, it's like having to make another planet. And then when I Googled second Earth, I found out there is a second Earth, and it's called Kepler 186f, if anyone wants to Google it later. So that's another model of care. And there are tribes who have done things to create cancer centers or parts of cancer centers at their facilities. So it can be done, but it's also not viable for every facility to be able to replicate all the things that are in a cancer center. And then this is the last model, which is the one that currently I think is my best thought on the matter, is that it really should be kind of a hybrid and a matter of building bridges between the tertiary centers and the tribal facilities. And it can't be that any one partner is doing all the work, because then that's really not a partnership. So each has to build bridges that work both directions. And that might mean that sometimes those from a tertiary center are sending out some of their docs to have clinic on site at reservation facilities. So it's not always a matter of we've always got to get everyone from the reservation to the tertiary center. We can send out people to be on site. And then this is some work that I did about breast cancer, and I'm bringing it up not to really get into the details of the research, but to kind of illustrate this idea of building bridges. So I asked the question, are there disparities in the types of operations we're doing for women who have breast cancer, comparing American Indian, Alaska Native women to white women? And why I ask this is that we know that disparities exist in cancer-related outcomes. And we know that mastectomy and breast conserving therapy with lumpectomy have similar survival. And lumpectomy has fewer complications, less pain, faster recovery, and better quality of life. So I wanted to know, are people getting that at equitable rates? And they're not. So there are more Native American women receiving mastectomy for early stage disease than white women. So if you look at the rates overall, 41% of Native women get mastectomy compared to 34% of white women for early stage breast cancer. So we're talking about stage 1, stage 2, something that might be amenable to lumpectomy. And then there are regional variations in that. So if you look at Alaska and the Northern Plains, nearly half of the women there get mastectomy for early stage disease. And we don't know the reasons why. That's kind of the next phase of research, but it's something that we don't have to settle for that. And I don't think we have to wait for a long, a long, thorough investigation to starting to do something about it now, because otherwise that's too defeatist. So I feel like I can get my patients what they need right now, in today's working world. And it's a matter of really thinking about multi-directional coordination. So we work with the tribal health facility. It involves the tertiary referral center, so a major cancer center. And then the clinicians, that's a whole multidisciplinary cohort that involves surgical oncology, medical oncology, radiation oncology. We work with social work to help with transportation, temporary housing, gas cards, work with patient navigators to help with some of those same things, and then some of the emotional support along the way. And then we work with traditional healers. It's never made sense to me to be in opposition. I think that we can really synergize the care for our patients together. And this schematic really would be applicable to any particular cancer subtype. But in the center, I have things that are more specific to breast. So what we'll do is we'll cluster our visits with surgery, medical oncology, and radiation oncology all to the same day. There's really no reason that patients who are making such a long distance drive have to come 3 separate times. And so we coordinate and we see them all at the same time. We utilize telehealth where we can. Not everything has to be done in person, and nothing should be shortchanged. But if it's something that is going to be a matter of discussion, we might be able to save patients some distance. We provide transportation and housing services. Sometimes we have to tap into community grants to shore up the gaps for any kind of funding issues. There are accelerated radiation courses, so radiation is an important part of breast conserving therapy. And in current times, we've had the ability to do shorter courses that cuts down some of the driving. If a patient's getting reconstruction, then maybe doing direct to implant instead of doing tissue expanders and then a separate operation to finalize the reconstruction. And then getting people who are eligible enrolled in Medicaid and Medicare, again, to manage pay gaps. In terms of journey, it looks like this on any bio, but I think it's important to know that it really looks like this in terms of lived experience. And that's a message that I wanted to make clear for students. Like anybody that you're looking at, an instructor, a mentor, you always see kind of the straight arrow course, but everybody has twists and turns. There were times that I had to take time out from this journey. So between college and med school, I took some time off. I did research in Memphis. I worked at the Smithsonian for the National Museum of the American Indian. I worked as a coffee barista. Sometimes you just have to earn money to pay for your applications for things. I did an extra year also with med school. That was to do research, array rotations, kind of figure out what I wanted to do. In surgery residency, I also had a little bit of time out. that was built into our program. I used it to do an MPH and some other research. So there are times that you can set aside to figure things out, and I did. In terms of medical school, I kind of thought I wanted to do internal medicine, and then was really surprised when I liked surgery, like shocked. I wasn't prepared for that. Um, I did away rotations at IHS facilities in Chinle and Belcourt. I went to Beijing and studied traditional Chinese medicine. I went to Medellin, Colombia, and did a trauma surgery rotation. I rotated through all of these different fields with the intent of trying to figure out, is this where I really want to be? And ultimately landed on surgery and was really set on it. And I think the reason why was that the OR was the place where I felt the most connected to my heritage. And I think that is not expected. It certainly wasn't by me, and it's not going to be the common thought of other surgeons at the operating room is something like a beading circle. But for me, it was. And it's because the approach to learning was quite similar. So when I learned to bead, I was 12 years old, and I spent the summer with my grandma. She taught us our patterns and worked with me just all day into the night, and stood over my shoulder and told me, this is what you do. No, do this. No, do that. It took a lot of concentration. And in surgery, the OR was the same way. So we had elders who we call attendings, and they, hovered over us and said, no sew here, no cut there. And it was, endless hours of concentration. So it felt really, really familiar. And I loved it for that. And I kind of think of like the progression as from my first pair of earrings. This is like it's either the first or one of the first Dreamcatcher earrings that I made. And then here's a pair that I did 10 years later. And that's kind of the progress between the beginning and the end of a surgical training experience. So it took about 10 years to become an independent surgeon. And you can see with the first pair, like the web is loose, it's not symmetric, there's not even a clear hole in the middle. So, you worry like, how are the good dreams going to find their way through the middle if it doesn't look any different than the rest of the web? And then, by the time I got to like a more advanced stage with my beading, then, the web is tight, like really tight. You wouldn't know it's thread. It feels like metal when you touch it. I was able to, do an embellishment all the way around the circumference. On the left, I used long twist bugle beads to kind of get through the distance faster. And on the right, I could do like each individual bead one by one. And with the left, it took so much effort, like probably 4 times the amount of effort. But then with anything, whether you pick surgery or something else, it takes a lot of practice, and you just practice over and over again until you perfect your craft. And that's what surgery was for me. It was that same kind of transformative process. I put this on here just to show really the details don't matter, but more this impression for students. I've had a lot of research attempts that have just not worked out. And I think the same could be said of any of your mentors. So I had 3 summers of lab research, a year of working on an IPMN nomogram, another year interested in this other program, years working on a walnut proposal, so many meetings that never led to anything, and projects that turned on and off all the time. And it adds up, but it's something that I feel like we need to share and expose with each other. Like, we don't talk enough about our quote unquote failures. Everything as a student to me looked like, man, everybody has their act together, and everything that they start gets done, everything that they do gets published. And I had no publications from any of this, and it was frustrating. But I think that it was character building, and somehow it helps and contributes to the research that I'm doing now. So just know that. And then in closing, we covered the obesity, inflammation, cancer link, prehab, and how we're using those 2 areas of science to build an indigenous anti-inflammatory prehab to change the tumor microenvironment, with the hope that we could slow down tumor growth just by living a healthier lifestyle. And then we also talked about the idea that bridges enhance the delivery of multidisciplinary cancer care. And for the students, my I don't know if this were like a valedictory speech, there would be some sort of adages to tell you. So follow your heart and listen to your gut. I've always done that, and I think it's worked out well for me. Know that most journeys have zigzags. They're not all straightforward paths. Study hard, work hard, practice. It does take a lot of hard work, but anything that is worthwhile does. And then be open to surprises, like my surprise that I would like surgery. So you could find there might be something yet you haven't discovered that is going to be your thing. And so it's good to have an open mind. And with that, oh, one last thing that I wanted to point out as a practical matter. So CURE, which stands for the Continuing Umbrella of Research Experiences, it's a program at the NIH, and it's something that helped me out, and I wish I had known about it sooner. So the idea is that it will support students through all stages of their education and career, beginning in middle school. I joined late on that pipeline. So at the postdoc phase is where I joined, and they've helped me out as an early stage investigator. But if you're a student right now and you're kind of trying to think of research programs, internships, mentored opportunities, funding opportunities, you might want to look into CURE. I think they've been fantastic for me. And like I said, I wish I knew about them sooner. So with that, Miigwech means thank you in Ojibwe.
Awesome. Thank you so much, Dr. Erdrich. I do want to go ahead and I'll share my screen again to bring us back to the Q&A, but really awesome presentation, really motivating and thoughtful. It's so nice to hear those different perspectives. So thank you for sharing that with us today. So with that in mind, we'll go ahead and move into our Q&A session. We do have about 15 minutes for this. You'll see in the bullets there that we do want to prioritize questions from our student audience first, and then we'll go ahead and move it on to the broader audience after that. There are different ways you can do this. You can feel free to unmute yourself, or you can use the reactions to raise your hand, or you can just drop them in the chat and then we'll go ahead and read them off for Dr. Erdrich. I do see 2 new messages in the chat. Oh, thank you, Carm, for conveying all of that as well in the chat. And as she said, don't be shy. This is a great opportunity to engage with Dr. Erdrich, either on her research work, her academic journey, anything like that. She shared a lot of great insights with us. So I'll go ahead and be quiet for now if someone has a question coming through. Maybe as you're thinking of that thought or how you want to put that together, or maybe you're typing in chat. I think I do have a question myself, Dr. Erdrich, and you touched on it briefly with the, oh, wait, no, I see Dr. Ingram has raised her hand, so I'll let her go first. Maybe she's asking the same thing I am. So go ahead, Jenny.
Sure. What a wonderful talk. Thank you, Jennifer. It was awesome. So it sounds like you have done a ton of things. So I was just wondering how you came across all these different opportunities and how you balance them, because it just seemed like, you seem like you should be like 100 years old with all the things that you've done. So I'm just curious to know how you're able to take advantage of these opportunities, and they're so varied. They're not just all these NIH opportunities. So if you could just maybe speak a little bit to that, that would be awesome.
Thank you. Yeah, that's a great question. I think it's probably that part where I was saying be open to surprises and not always having a preset agenda or having a rigid agenda. So like, for example, did I ever think I was going to spend 3 months in Beijing, China, studying traditional Chinese medicine? No, that was never a preset goal. But then, I heard about the opportunity, so then why not apply? And maybe also because I've taken some time along my journey and not done everything where it was like college, then boom, medical school, then boom, residency, like I've taken some time, some loops like I showed. And I think that's actually where some of the most interesting stuff has happened, is when I've stepped aside. Um, and that probably is what sets it apart from those who've gone straight through everything. Like they just haven't had time, not that they necessarily weren't presented the opportunity. It was just a matter of time. So I guess creating pockets of time. In terms of balance, I don't always feel very balanced. So I don't know if I have the right answer on that one. But yeah, does that answer it, Jenny?
Yeah, it sounds like trying not to be too mapped out and just take advantage of opportunities as they come. So thank you.
Yeah, thank you.
Thank you for that, Dr. Erdrich. I think that's some good advice for our students to consider as well, as they're navigating their own academic and professional journeys. We do have a question from one of our students. She is a member of our NASFAC program, and her question is, what was the recruitment process on your research? How did you handle or address the conversations with cancer patients, especially with cancer being a stigma?
So I started with the social workers. Actually, the tribal partner that I'm working with, they have social workers who are dedicated to cancer navigation. And so I thought, let's start with their knowledge. They have the best understanding of their community and how this is going to go over. So first was just floating the idea by them and making sure that it, would be of use or interest to them. And since it was, they were supportive, and they thought that their reason for supporting me was they thought it would help their patients. And then they did the recruitment. So I think that's an important lesson really for any of us, is we have to, out of respect of sovereignty, we should really let our tribal community partner be the one that delineates the approach for recruitment and conducts it themselves. So I kind of, I really didn't have to do the recruitment, essentially, is the answer to your question. And if that was wanted, I would have, certainly, but they managed it all. So I think that was kind of the best move I could have done, is not be the one in charge of it. Just get to meet the patients who've already been recruited.
Thank you, Dr. Erdrich. Great response, and I think that really shows the strength in putting the community in the expert role or the expert seat, since they're most familiar with their fellow community members and their wants and needs. I I don't have another question in the chat yet, but as people are formulating them, that was just one thing I really appreciated about your presentation, was I never had heard about prehab, only rehab. And it never, I just never considered, we, as a public health professional, it's always been, that primary level of prevention and looking at things from beforehand and everything, but I've never considered prehab. And recently my cousin had surgery for gallbladder removal, and they did some preparation with her here at FMC, but it was kind of the usual stuff you hear. Don't be eating any foods. There was a liquid diet before, some things like that, but really never any of this stuff that you're sharing with us, or even the intentionality behind it. So I'm wondering if there's other examples you've seen like that before. I know you said this was kind of the first one for American Indians, Alaska Natives, but I'm wondering if you've heard of other examples like that, or if this is really novel in its development and practice.
Thanks for that question. Yeah, I love talking about prehab. It's actually, there are many examples out there. I've read up on hundreds of existing prehabs to try to learn from them what they're doing, what's working, what's not working, what kind of outcomes they're measuring, and tend to have a pattern of showing some evidence that it might be significant across studies. So they're definitely out there. They're growing. This is kind of a hot area that's expanding pretty rapidly. The American College of Surgeons definitely has a lot of promotion of prehab. They have a program called Strong for Surgery. So it's out there. It's just that Native American people haven't been part of the recruitment, part of those getting to participate, at least not in any dedicated, customized way. So it's, not something we're inventing. We're tailoring it. We're making it community specific and hopefully meaningful. And what we're doing isn't necessarily going to be something that can then just be replicated for a different community. But hopefully the process of what we did is something that could be used as an outline to follow.
Great. Thank you for that response. We did have another question come in the chat from Utana Daisy. It may touch on, the first part may touch on what you just said, but she said, how did you come across the idea of promoting prehab and knew it was right for Native American communities?
I think it was several things at once. So I don't know, maybe this goes back to Janny's question a little bit too, about like, how do I come across these things? I think it's just being open to the universe. I feel like that's something that my father's approach is that way too. Just I guess, yeah, listening to the universe is the best way I can describe it. And so a lot of things were happening at once, like the talk about prehabs from the American College of Surgeons. That was kind of happening. There was a friend of mine who was doing prehab for her surgical patients. I got here and there was some effort to do some preoperative optimization, but it wasn't called prehab. So, someone else was kind of working on it. And then it just seems like kind of anywhere I went, it was just kind of infiltrating in to then you reach that point, you're like, I think I need to pay attention to this. And then I had a sit down meeting with my mentor, Dr. Cindy Thompson, who started talking about prehab also. And I don't even think that was the agenda item for the meeting. And then she's connected to NACP. So she's been mentoring people through NACP for a while. And so then it seemed like, okay, that's another stepping stone toward the idea. And I have always planned and wanted that my career was going to be dedicated to helping tribal populations. So that part, that's not just a kind of, let the universe decide, like that. It has always been something that I have been very set on. Like that has had a lot of direction and motivation. How it gets done, that's how the universe decides. But that's what I want to do with something that I absolutely knew. So then it seemed like, well, if everyone's getting to do prehab, and I'm reading about it by the hundreds, why doesn't my community get to do it? And so it just kind of took off from there.
Great, thank you for that. Well, we do have 4 minutes left, so I do want to leave room for possibly one more question if anyone has one last burning one here for Dr. Erdrich. We will have Dr. Erdrich stay on just a little bit after our webinar time wraps up for any one-on-one discussions or questions that anyone might have. Thank you all for who provided questions already. These are some great engaging topics. Oh, we have one more, it looks like. Did you have any experience to prehab before tailoring it to tribal communities?
Not in a formal way. I feel like I do it for my patients, those who needed it. I was always working on trying to optimize them, but not in like a systematic, institutionalized, this is labeled prehab kind of way. So I think that part I had experience at. And then, like I mentioned, I had exposure to it from a friend and now mentor who's running prehabs in her surgical practice, and then that's it. And then, you know, a lot of it is just reading, constantly reading about all the prehabs, and then assembling mentors who have done prehab. So I think that's important too. That's actually, you know, hugely important, is having a really strong mentorship team. So I'm not doing this as an island unto myself. I definitely have people who are coaching me through it.
Great. Thank you for that, Dr. Erdrich. Well, let me see. I just had the chat go off again. All right, no, it is Carm. Everybody. So with that, I'll just go ahead and close us up here then, since we are approaching the hour. Just want to thank everyone again for joining us here today, and for Dr. Erdrich for being our feature presentation and sharing all of her knowledge and insights with us, especially from a surgeon's perspective. That's not one we've gotten in the webinar series yet, so we're very grateful for you for sharing your valuable time with us. I do invite everyone in the audience to either type in that URL or scan the QR code with a mobile device that has camera features, just to link to our evaluation survey. We really love to hear your feedback, and it really goes into the development or future webinars. So I invite you to do that. It'll be fairly short, but for everyone, just thank you for being here today and sharing this space with us. We do hope you have a great rest of your day. And as I said, Dr. Erdrich will be on just for a little bit after if anyone has any one-on-one questions. But thank you again. Have a good day, everybody.